So I just wanted to thank everyone for joining us on this Monday morning, bright and early. Particular thanks to Drs. Skeik and Gössl who are joining me today. We are going to be doing a joint presentation discussing the topic of anticoagulation in patients who also need antiplatelet therapy. How low can we go is the theme. And the reason that I chose this topic and asked Drs. Skeik and Gössl to join me is that I was asked to give a version of this talk at the Minnesota ACC this past fall. And frankly, when I was asked to give the talk, I was really wondering whether there is anything new under the sun to discuss in this topic. But as I started to look into it, I realized that there was actually quite a bit of new data that I thought would be important for us to share with our group, and also hopefully open up discussion about protocols that we might generate going forward across our practice. So what we will be doing is we're each going to be giving our presentation 15 to 20 minutes each, maybe a little bit less, and then we'll do questions at the very end. So by way of overview, I will start out by talking about the most recent guidelines for oral anticoagulant use in atrial fibrillation. I'll also provide a brief history of anticoagulants and antiplatelet agents. I'll give a brief update of the 2019 atrial fibrillation management guidelines and touch a bit on the left atrial appendage occlusion device, the Watchman. Dr. Skeik will then discuss the pharmacology of antiplatelet agents and anticoagulants, as well as touch on bleeding risk. And Dr. Gössl will close with a discussion of how to manage dual and triple therapy, and also touch on whether or not there would ever be an option to continue with oral anticoagulants alone in patients who have coronary artery disease. I'll just flash these two tables up here, figures up here from the 2018 North American guidelines, as well as the 2018 European guidelines. I'm not going to go into any detail. Dr. Gössl will be discussing these at the very end, but it's these guidelines that were really the impetus for my choice of this topic, just because I think there are some cutting edge ideas in here that we'll discuss at length. So just taking a step back, bird's eye view, the scope of the problem that we're addressing today, 1 to 4% of the adult population in Australia, Europe, and the United States have atrial fibrillation. About 1% of patients between 18 and 64 years old have atrial fibrillation. Interestingly, 7% of whom are undiagnosed. And when you move into patient population greater than 65 years of age, about 10% of the population has atrial fibrillation, and with 10% of them being undiagnosed, and greater than 13% of octogenarians have atrial fibrillation. 20 to 40% of patients with atrial fibrillation also have coronary artery disease by the literature, although I would suggest that actually it's a higher percentage when we look at the amount of coronary artery disease that's present on the cardiac CT scans that we do pre-AFib ablation. I would say 90+% of patients who go on to have a pulmonary vein isolation also have coronary artery disease, even if it isn't obstructive. 20% of patients with atrial fibrillation will go on to need PCI or have acute coronary syndrome. And 5 to 10% of patients referred for a left heart cath and possible PCI have an indication for an oral anticoagulant for atrial fibrillation. So this is a very important problem. So I always think it's instructive to look back to history as we start to think about these topics. So let's just start with a question. And obviously, we don't have a mechanism for you to vote, but just kind of consider what your answer is. So did you know aspirin was first distributed A, as a powder in 1899, B, as a tablet in 1934, C, as a liquid in 1849, or D, as a powder in 1921? Probably all of you guessed that aspirin was first distributed as a powder in 1899. And it was distributed acetyl salicylic acid as a powder by Bayer, and was called aspirin at that point. although it had been around for a very long time prior to that for use as an analgesic, even in the ancient literature. 1991 is when ticlopidine was approved. And then in 1997, roughly 100 years after aspirin was starting to be used, clopidogrel was FDA approved, followed by prasugrel in 2009. In 2011 was ticagrelor, and in 2014 it was vorapaxar, and Dr. Skeik will be talking to us a bit more about all of these. So how about warfarin and warfarin's history? So did you know warfarin was first distributed A, as an insect repellent in 1944, B, as a household cleaner in 1952, C, as a rodenticide in 1952, or D, as a sleep aid in 1954? And I'm sure you all guessed the correct answer here is C, as a rodenticide in 1952, probably because we are reminded of this fact by almost all of our patients as they come through our clinics when we're recommending warfarin. So a brief history of oral anticoagulants. After 1952, when it was used as a rodenticide, warfarin was approved for human use in 1954. Interestingly, it was also in 1954 that digoxin was FDA approved as well. 2010 is when dabigatran was approved, followed by rivaroxaban in 2011, apixaban in 2012, edoxaban in 2015, and betrixaban in 2017. So let's move on to a case. Mr. Smith is a 50-year-old male with past medical history of hyperlipidemia who presents in clinic to discuss the management of a new diagnosis of paroxysmal atrial fibrillation with a recent cardioversion in the emergency room. He is otherwise healthy with a structurally normal heart by echo. You recommend no anticoagulation, B, aspirin 81 milligrams daily, C, rivaroxaban 15 milligrams daily for a month and make sure he takes it with food, or D, rivaroxaban 20 milligrams daily for a month, be sure to take it on an empty stomach. So the correct answer here is no anticoagulation is required. This gentleman has a CHADS-2 VASC score of 0, and therefore by the guidelines, no recommendation for any anticoagulation. Some of you may have guessed aspirin, but actually in the newest guidelines, there's really no role for aspirin for stroke prevention from atrial fibrillation. Whether or not he should be on it for primary prevention of cardiovascular disease would be a separate question, although I suspect that would not be the case either. I just flashed rivaroxaban as an option up here with or without food, just to highlight the fact that it is extraordinarily important to emphasize to your patients when they take rivaroxaban that they take it with food. You'd be amazed at the number of patients whose cardioversions are canceled or switched to a TEE because they were not taking rivaroxaban appropriately. There's about a 30% decrease absorption with rivaroxaban if it's taken on an empty stomach. So just to review what came out in 2019 with the AHA, ACC, and HRS focus update for the management of patients with atrial fibrillation. When you look at stroke risk and atrial fibrillation, and you look at stratifying by 3 different categories, the first category is a CHADS-VASC score of 0 in men or 1 in women. And in this category, it would be reasonable to omit an anticoagulant therapy. If the CHADS-VASC score is 1 in men and 2 in women, oral anticoagulant may be considered, and this is obviously an individual discussion with patients. And when there is a CHADS-VASC score of 2 or greater in men or 3 or greater in women, oral anticoagulants are recommended. And so if you think about it, in fact, it should be called the CHADS-VA score, because the sex category does not seem to play as large a role in terms of risk stratification for stroke, according to the newest guidelines. I'll just show this slide, which looks at the risk of stroke or death in the Women's Health Initiative population of women with atrial fibrillation. So the CHADS-2 and CHADS-VASC scores do seem to be valid in a female population, although if you're looking only at women, it can't tell you the proportional increased risk within this gender. I actually looked at this population to validate the CHA2DS2-VASc score, and we found that it was a valid score in this population of women, although our risk of stroke was actually somewhat less than is published by many of the studies done by Dr. Lip, who developed the CHA2DS2-VASc score in 2010. Interestingly, if you look at annualized rates of death by CHA2DS2 and CHA2DS2-VASc score, there is a very substantial morbidity, not even accountable by stroke, as you have an increasing score. Just to briefly touch also on bleeding risk scores, this was a table from the Journal of the Minneapolis Heart Institute Foundation that we published in 2017, just summarizing many of the major bleeding risk scores. And of course, the frustrating part about bleeding risk is that hypertension, age, female sex, diabetes, all of these are risk factors for stroke, but also happen to be risk factors for bleeding. And Dr. Skeik will be touching more on this topic. So just wanted to highlight a few more points from the 2019 AFib guidelines. One is the definition of valvular atrial fibrillation that we've all talked quite a bit over the last few years about, gosh, well, what does that mean? Is it moderate mitral regurgitation? Is that considered to be valvular atrial fibrillation? But by the newest guidelines, valvular atrial fibrillation would mean moderate to severe mitral stenosis or a mechanical heart valve. The 2019 newest guidelines recommend a direct oral anticoagulant over warfarin use, and it's a class 1A recommendation. Another highlight is that in addition to annual renal function for DOAC monitoring, which I think we all do anyway, there's a recommendation to monitor hepatic function because there is a signal of a small amount of patients that get a hepatitis from DOACs. And so our electrophysiology clinic has started checking AST and ALT annually for patients on DOACs. It might be reasonable to prescribe apixaban for patients with end-stage renal disease. I think a lot of us have been hesitant to do that, but it is thought to be safe in this population, even if they're not on dialysis. Another highlight is the role of percutaneous left atrial appendage occlusion that may be considered in patients with AFib at increased risk of stroke who have contraindications to long-term anticoagulation. And I think this is an important point. I think many of us have had patients come through our clinics requesting Watchman because of the direct-to-consumer advertising that is out there. But really, the gold standard is that we offer it only to patients who have contraindications or intolerant of long-term anticoagulation. Another highlight is the implantable loop recorder to evaluate for atrial fibrillation in patients with cryptogenic stroke. And of course, I continue to be incredibly proud of our electrophysiology team who really were pioneering the use of this tool even before the guidelines were published. So I just wanted to move briefly on to the Watchman device and just a few issues regarding Watchman. So start with a case. Ms. Roberts is an 85-year-old female with past medical history of persistent atrial fibrillation who had recurrent GI bleeding on oral anticoagulants, leading to a Watchman placement greater than 6 months ago. She has had ongoing diastolic heart failure despite rate-controlled atrial fibrillation on metoprolol, and desires a rhythm control strategy if possible, as she feels so much better in normal rhythm. So you recommend A, an AV node ablation with a micro pacemaker, B, change her rate controlling medication to diltiazem instead of metoprolol, C, tell her that her symptoms have no solution and that she should just kind of adjust to her new normal, or D, a TEE guided cardioversion. So there is some new data that a TEE guided cardioversion might be reasonable here, even if she's only on antiplatelet therapy and not anticoagulated. There are two studies I just wanted to highlight here. One is an abstract, and the other one is a larger cohort published. The first was an abstract from 2019 that demonstrated, that looked at outcomes of cardioversion after left atrial appendage occlusion in patients with Watchman device. There were 33 cardioversions in 19 patients, 40% of whom were off anticoagulants. TEEs, interestingly, was only done on 30% of the patients off anticoagulants. There were no CVAs or TIAs at a median follow-up of 459 days. But interestingly, there were 2 bleeding events in the patients on aspirin only. And I think this highlights the fact that aspirin does have some morbidity in terms of bleeding. It's not just a benign medication. The next study and second study is direct current cardioversion of atrial fibrillation in patients with left atrial appendage occlusion devices. This was a larger study looking at 148 patients. 100% of them had a TEE, unlike the previous study. They found 2.7% did have a left atrial thrombus on TEE, so those patients did not get a cardioversion. 43% of the patients without had no oral anticoagulation after cardioversion. There were 3 TIAs, a median follow-up of 12.8 months, none within the first 4 weeks of cardioversion. So this looks quite promising. There were 6 bleeding events in follow-up. Only 1 was proximal to the cardioversion-related anticoagulation. So just a brief review of anticoagulation with Watchman, which very honestly, I frequently have to look up myself, quite nuanced. So when patients have the device implanted, they need to be on warfarin with therapeutic INR. They're on warfarin and aspirin daily through 45 days, at which point they get a TEE to look for a leak. And then if there is not a leak greater than 5 millimeters, they switch to clopidogrel and aspirin. Clopidogrel and aspirin is continued through 6 months, and then aspirin only after 6 months. So I just wanted to show you briefly a proposal by Tamara Langeberg and Dr. Gornick, who again are always on the cutting edge of newest treatments and trying to provide best practice for our patients. Now this has not been finalized, and it's really only we're currently chatting about whether or not we feel that this would be reasonable to pursue. But based on the limited data that we have, one thought would be that for patients who have less than 6 months after their Watchman, of course, we would do a cardioversion if they were therapeutic on warfarin for 3 consecutive weeks, because that would be consistent with current guidelines. But that you would do a TEE guided cardioversion if they were subtherapeutic on warfarin or on aspirin and Plavix only, and then they would be on anticoagulation per protocol, so potentially on dual antiplatelet therapy alone and not oral anticoagulation. If they're greater than 6 months post-Watchman, you would always do a TEE guided cardioversion. But if there is no thrombus and no significant leak, you could consider continuing aspirin only as their anticoagulation. And again, this has not been formalized yet, but this is a thought based on the recent data. So what is next in anticoagulation for atrial fibrillation? There are so many questions that are still being evaluated, ripe for studies, maybe some of which will come through the foundation. One is to look at DOACs pre and post Watchman, DOACs post TAVR or post bioprosthetic aortic valve. How about anticoagulation after surgical left atrial appendage ligation? What do we do with that? How about Watchman with antiplatelet agents only if they can't be anticoagulation? As I mentioned, cardioversion after a Watchman without anticoagulation. Or another area that we're starting to evaluate in our own group is cardioversion if you have a cardiac CT that doesn't show a left atrial appendage thrombus, even if you don't have a TEE. And then another area of interest is device-detected atrial fibrillation and trying to elucidate how much atrial fibrillation is important. So with that, I will stop and say thank you, not only to my partners, but also to the men in my life, and I'll pass it on to Dr. Skeik.
All right, good morning, everybody. I believe you can hear me, hopefully. It's a beautiful morning after 2 days of heavy rain here, and thank you for being on the line this morning. And Dr. Moore, thank you so much for the introduction. This is not the first time that I have a ground round with Dr. Moore, and it's been a pleasure. And thanks, Dr. Gössl, for joining us as well, too. Without any further ado, I hope my haircut is okay, because my son helped me do the haircut yesterday. I don't know how I look like. I can't see myself. But at any rate, let's take it off. So I'm going to cover the portion of risk and benefits of different antithrombotic therapy, focusing on atrial fibrillation. These are kind of a few disclosures that I have here on the screen. So we're going to focus on different antithrombotic therapies in terms of mechanism of action, general comparison. I'm going to focus on bleeding risk for each option, and we're going to finish with summary. So I expect that all of you know the coagulation cascades by heart. Just kidding. You can see that the coagulation cascades are very, very, very complicated to comprehend, but also decisions making through these anticoagulation cascades, so related to the anticoagulation management, could be much more complicated than the cascades itself. Sometimes I have to think like, 100 times and ask my colleagues what do they think about starting anticoagulation or stopping anticoagulation for certain patients. So decision making can be very, very complicated. You always have to weigh the risk and benefits of anticoagulation. And now if you want to add an antiplatelet therapy to anticoagulant, this is going to entail or need more thinking. So target for anticoagulation, we've had vitamin K antagonist warfarin for many years, as Dr. Moore mentioned, since 1954. And then we know what it targets, but now we're dealing with a new era of anticoagulation, like talking about direct factor 10 inhibitors, including rivaroxaban and edoxaban. And we only have one direct thrombin inhibitor orally, which is dabigatran, as you see from the slide here. So if we talk about the direct oral anticoagulant briefly, if we start with dabigatran, which is the only oral direct thrombin inhibitor, approved indications including non-valvular atrial fibrillation, is, as a matter of fact, it's the only direct oral anticoagulant that showed superiority over warfarin to reduce ischemic stroke, and that's why we give anticoagulation for patients with atrial fibrillation, to reduce ischemic stroke. But unfortunately, that came with the expense of increased more of major bleeds, especially in patients who are 75 years or older. And mostly those bleeds were GI or extracranial bleed. It's also indicated to treat patients for DVT or PE. And again, there's a pitfall here that we have to do 5 to 10 days of parenteral anticoagulation before starting dabigatran. It's also indicated for risk recurrent reduction of VT after initial therapy. Also indicated for DVT prophylaxis after hip, but not knee replacement. So we have multiple factor 10 inhibitors in the market, including rivaroxaban, edoxaban, petrexaban. There are much more in the work at this point. Let's start kind of briefing, provide a brief on each one of these anti-10As, starting with apixaban. It's again indicated for non-valvular atrial fibrillation to reduce stroke and systemic embolism. As a matter of fact, it showed superiority versus warfarin for stroke and major bleed, as well as all-cause mortality. It's the only direct oral anticoagulant that was actually compared to aspirin in the various trials, showing superiority for stroke, as well as no significant difference in terms of major bleed. It's also indicated for the treatment of DVT and or PE. It actually shows superiority versus enoxaparin/warfarin for major bleed. It's kind of stressing the safety profile of apixaban. Also, risk recurrent of VT after initial therapy. Again, you don't have to really use 5 to 10 days of parenteral anticoagulation for VT management. It's also indicated for both hip or knee replacement to reduce DVT risk. Riva or rivaroxaban, it's actually the one that has most indications nowadays. Recently we got 2 more indications added to the indications of rivaroxaban. Again, non-valvular atrial fibrillation, it can be given once a day, but like Dr. Moore mentioned, you must tell your patients to take it with food. I've seen it quite often that patients come back with a recurrent thromboembolic event because they have not used it with food. It actually showed more GI bleed and transfusion versus warfarin. It's also indicated for the treatment of DVT and ORP. It actually also showed superiority versus enoxaparin/warfarin for major bleed. Also indicated for risk recurrent, for reduction of recurrent VT after initial therapy. I have to stress the fact that the current dosage that's approved is 10, not 20 milligram based on the Einstein choice trial. As a matter of fact, Xarelto was the only drug that's compared to aspirin for this indication, and it showed similar major bleeding risk versus aspirin in this subset of group of patients. It's also indicated for DVT prophylaxis after hip or knee replacement. Now, the newer indications, the most recent indication that Xarelto received is DVT prophylaxis in medically ill patient, but those patients should not have high bleeding risk to be candidates for this indication. Also, as you guys know, it's also indicated to reduce MACE in patients with chronic CD and or PED in addition to baby aspirin. So edoxaban or Savaysa, we don't use much of edoxaban, although it's a good option if you worry about major bleed and worry about kind of compliance, because it's once a day and shows superiority versus warfarin for major bleed in patients with non-valvular atrial fibrillation. And also showed lower GI bleed for the 30 milligram doses versus warfarin. It's also indicated to treat patients with DVT and P. And again, like Pradaxa or dabigatran, you have to use 5 to 10 days of parenteral anticoagulation. Also shows superiority versus warfarin for major bleed and clinically non-major bleed. It's not indicated for other indications. Very briefly, Betrixaban, it's actually not yet fully studied for non-valvular atrial fibrillation or the management for DVT and P, but currently it's indicated for VT prophylaxis in adult hospitalized medically ill patient. What do we have for antiplatelet therapy? I think Dr. Moore alluded to some agents that we currently have. If you think about aspirin, which is the ancient agent that we have had for many years, as you know, it actually reduced the production of thromboxane 2 by inhibiting cycloogenase 2 enzyme. As you know, thromboxane 2 is very strong, potent activator for platelet. So such inhibition will reduce the aggregation of platelet. And so the next we have actually the ADP or P2Y12 inhibitors, including clopidogrel, prasugrel, or ticagrelor. And these agents will inhibit the binding of ADP to P2Y12 receptors on platelet, inhibiting both activation and aggregation of the platelet. Third, we have most recently approved Verapaxar, which is a protease activator receptor 1 inhibitor, which prevents thrombin from binding to thrombin receptor on platelet. And as you know, thrombin is the most potent activator for platelet. So such inhibition will reduce platelet aggregation. And we also have the IV medications for GPU2B, 3A inhibitors. Those only come with IV format, and they also reduce the platelet aggregation. So these agents what we have currently to inhibit platelets. As Dr. Moore mentioned, we actually for the most part we use the ACC guidelines. The point I want to make here. Guidelines want us to balance between stroke risk reduction and benefit versus bleeding risk. So you always have to juggle between bleeding and thrombosis when you prescribe an antithrombotic therapy. The reason is, as I mentioned, the most important goal for giving patients antithrombotic therapy in patients with atrial fibrillation is to reduce risk of this. This patient that came down with the right side major MCA stroke with atrial fibrillation. But when you think about managing this patient, you have to think about this complication, which is intracranial hemorrhage, like this patient had with anticoagulation. That's why I'm not going to go over this in details, but we use different scoring system to kind of estimate the thrombotic risk by using CHA2DS2-VASc scoring, or using also Hasbled scoring to estimate the bleeding risk. The point that I want to make here, when you calculate the Hasbled score, if you will, you have to think about a yearly risk here. So if you think about a patient with Hasbled score of 4, while there is a 10% chance in the first year to have major bleed, it goes up to 60% for cumulative risk in 10 years. So you really have to think that wisely when you estimate the risk of thrombosis and bleeding. So what do we have in terms of options for antithrombotic therapy for atrial fibrillation? Let's start with aspirin. Based on meta-analysis, looking at 8 trials involving about 5,000 patients, aspirin really was not really a great drug to reduce stroke risk. It only reduced it by 22%. And there was a slim kind of risk of major bleeds, 0.23% per year. If you look at a meta-analysis for warfarin, which we had for a long time, it actually did a great job reducing stroke risk in patients with non-valvular atrial fibrillation or atrial fibrillation in general, 64%. That came down with the price of major bleed between 1 to 6% based on the trial. And there was an interest in Europe is checking the option of aspirin plus plasma alone, that actually did show some more reduction of stroke versus aspirin alone, but there also increased risk of major bleed. But as you know, aspirin Plavix did not really do fairly well compared to anticoagulation. If you ask me, why do I list aspirin? Do we see patients still on aspirin? As a matter of fact, based on Pinnacle registry, NCDR registry, unfortunately, we still see about 40 to 50% of patients with atrial fibrillation, despite having an indication for anticoagulation. You see those about 40, 50% of these patients with atrial fibrillation do not end up on antithrombotic therapy. Quite a good amount of these patients are on aspirin alone. We still do a lousy job in protecting our patients with atrial fibrillation. So now, directional anticoagulant introduced in the market, as I mentioned, and compared to warfarin, dabigatran, as I mentioned, had lower ischemic stroke, apixaban, edoxaban, lower hemorrhagic stroke and major bleed. All DUAC had lower ICH, and that's why now the current guidelines actually favor the DUACs over warfarin. They're actually much more convenient. They do not require monitoring. They have shorter half-life, and now we have antidotes, though the cost of the antidotes is kind of high at this point. We still see bleeding complications with the DUAC of course, but, less than, in general, less than warfarin. And we still have some issues with compliance adherence and dosing issues. That's why probably, like Dr. Moore mentioned, maybe Watchman device might be an option for these patients. Based on meta-analysis comparing, dabigatran, Epixa and rivaroxaban versus warfarin based on Rely, Rocket, and Aristotle. If you look here, these 3 agents showed less all-cause stroke and systemic embolism versus warfarin. They also showed less hemorrhagic stroke versus warfarin. If you look at the safety endpoint, these 3 agents also showed less intracranial bleeding versus warfarin. But we see some kind of signal for increased GI bleed that we didn't see with Aristotle or with apixaban in Aristotle trial. So this table summarizes the major bleeding risk for each of the DUAC, dabigatran, and apixaban, rivaroxaban, edoxaban, based on the pivotal trial that these drugs were studied in. For major bleed, ICH, and GI bleed, if you look at the major bleed percent per year, although they are less than warfarin, but we still kind of considerable percentage of these patients had some major bleed and ICH and GI bleed. But for the most part, they were less than warfarin. So for annual hospitalization for major bleed, about 117,000 for anti-10A inhibitors. We see about 117,000 annual hospitalization for major bleed. I'm not sure if you guys know this band now. They're being rocking around here. Anyways, annual deaths related to major bleeds with anti-10A inhibitors about 20,000 patients. So now, kind of getting into the topic here, patients with acute coronary syndrome and atrial fibrillation. As you know very well, that dual antiplatelet therapy actually are standard of care now to prevent MAS after PCR and ACS. And so there's a current debate about actually optimal duration for even dual antiplatelet therapy. There is a recent study now published recently in JACC about even ticagrelor being a single agent after PCR for acute coronary syndrome. So there are a lot of really debate how long even for dual antiplatelet therapy, even without the need for anticoagulation, what is the optimal duration for dual antiplatelet therapy. That's still under discussion. As Dr. Moore mentioned, approximately 5 to 10% of patients undergoing PCI actually do have atrial fibrillation. This question comes all the time. What kind of antithrombotic therapy for how long we should do for these patients? Because there are 2 dilemmas here. So while you're trying to prevent cardiovascular or MACE complication by using triple therapy, you have to worry about increased risk of bleeding and, using triple therapy in these patients. And also you have to worry about the other dilemma, which is withdrawing aspirin early on might lead to increased risk of stent thrombosis. So where is the balance here? So that's why we had actually multiple recent trials published to address the question whether dual antithrombotic therapy using DUAC plus P2Y12 versus triple therapy using warfarin, P2Y12, and aspirin. And these trials, like Redual PCI for dabigatran, Pioneer, AF-PCI for Roxaban or Gössl, recently published for apixaban, and Entrust AF-PCI for edoxaban. You see here the major clinical relevant or major bleed right here listed for you for dual versus triple therapy. And here is the major bleed. I'm not going to go over each number, but the message bleed actually were less with the dual therapy using DUAC plus P2Y12 versus triple therapy using warfarin, P2Y12, and aspirin. And I'm sure Dr. Gössl will allude to this more, and he's going to talk about the thrombotic outcome as well. So again, decision making can be really, really kind of challenging when you take in consideration stroke risk reduction for atrial fibrillation, and also you want to worry about stent thrombosis for acute coronary syndrome. So you have to think about too many factors here when you make your decision. So in summary, antithrombotic therapies, have different indications and bleeding risk. Direct or anticoagulants actually have lower bleeding complications than warfarin in general. The combination of antithrombotic therapy can carry higher bleeding risk, as we saw there. And currently, we know that bleeding complications, at least for DUAC plus P2Y12, are less than warfarin plus P2Y12 and aspirin. So I think, I'm going to set the stage to Dr. Gössl, from whom we're going to learn about what would be the best option for these patients based on also thromboembolic events. Thank you so much, and I'll be staying online for any further question at the end. Thank you.
Good morning, guys. Let me see here. Make sure that this works. Okay, my screen should be up. Yeah, thanks for the introduction. Thanks for everyone joining us this morning, and thanks for Nedaa and JoEllyn to have me join this fantastic talk. I'm going to go through just a few more slides so that we have enough time for questions. So my task was to really address more the PCI question. Let's see here if I can advance correctly. Here we go. So the update really for us from the interventional group is, I think, based on this paper, antithrombotic therapy in patients with atrial fibrillation treated with oral anticoagulation. There was an update in 2018. The update was really done due to these major two trials, and that's their main table here, the Dual PCI trial and Pioneer AFC trial. I want to point out that actually, and that's always a big question, I think, for me, that there's actually enough acute coronary syndrome patients in those trials. They have a safety and an efficacy endpoint. The safety is, of course, the bleeding events, and then the secondary endpoints more focused on the PCI outcomes. But overall, without going into too many details here, this could be a talk by itself, is that the antithrombotic therapy, and that is really meant to be this newer term where you say you have a oral anticoagulant and one P2Y2 inhibitor, and we'll get to that, what the choices are there. That's the antithrombotic therapy, and basically avoiding aspirin. Based on these trials, the antithrombotic therapy, so again, an oral anticoagulant, either this rivaroxaban or dabigatran with a P2Y12 is superior, or at least non-inferior to the therapy that we used to do, warfarin and maybe even triple therapy. So then they came up with this update here, and you can see it's getting quite complex, and that's why I brought this up, because this is basically what we're supposed to do in our head every time we do a PCI or when you refer someone. But we have procedural consideration, you can see here, and we'll get to ischemic thrombotic. It would be great to have an audience now and see all my interventional colleagues sitting there and simply ask someone randomly what they think is high ischemic or thrombotic risk, and maybe someone can put a question out there online, because I think we would probably all not necessarily agree on what we think is one or the other. Procedural considerations are important, and then also what is the post-procedural consideration. But nevertheless, the most important guidelines are really now that the NOACs are actually preferred over the warfarin therapy at the lower doses, and the lower doses are not recommended. So you specifically have to use the doses that are used in those trials. If you stay on the warfarin, you want to keep the INR really on the lower side. On the antiplatelet therapy, really clopidogrel is preferred. You can use ticagrelor, but you shouldn't use prasugrel. And really aspirin therapy almost only through the PCI phase only. We'll get to the nuances there. And then here, of course, various recommendations, whether or not you go for 6 months or 1 year of single antiplatelet therapy on top of the NOAC, get to that as well. And then really the triple therapy is not in favor anymore. Nevertheless, everybody recognizes that there might be some patients, especially those with ischemic risk, where you might consider that. We'll get to a table soon. But again, this would be nice for an audience. But what is high ischemic risk? So I really looked around and said, okay, what would I consider a high ischemic risk? And there's actually some papers that try to put it in their methods. I think we would all agree that an acute coronary syndrome is a high ischemic risk. And then there's papers that put these here, for example, out. You can pick one up, but it's pretty clear. Bifurcation lesions, for example, if you use a lot of stents, if you use a CTO procedure. In this paper, for example, left main wasn't mentioned. I personally would consider a left main lesion as a high ischemic risk. But here you can already see there's many definitions, and I think, again, out of 10 intervention cardiologists, I'm not sure how all we would agree on, one definition. And what is a high bleeding risk, right? So how do you define that? There's also these calculators. Are we really using calculators all the time? And this one is certainly a good one. You can put it on your iPhone, and you can put some numbers in here: hemoglobin, age, white blood cell count, and creatinine clearance. You get a number. Again, numbers down here, you don't have to remember it right now, but for this patient, for example, the number was 22, so moderate risk, and then it puts you basically the 12 to 24 months dual antiplatelet therapy versus the short duration. And you can see that in this particular patient, ischemia would be reduced, but bleeding is kind of equal. So in this patient, you could probably say, yeah, I probably go for the longer duration of antiplatelet therapy, because bleeding is not really necessarily increased for this patient. It can help you. Now, Augustus, as Nedaa mentioned, there came some interesting studies out, and one of them is, or results out, one of them is this aspirin question about the 30 days, right? And I think the 30-day aspirin question for the first month, basically, should we do triple therapy? Should we add the aspirin on top of the Plavix, for example, and oral anticoagulation? What they show here on the left side, if you give aspirin or a placebo for the first 30 days, you will definitely have more bleeding. But on the other hand, if you give the placebo versus aspirin, you also, with the placebo, you have more stroke risk, and you have basically what we don't want to see: stent thrombosis, MIs, etc. If you then look first beyond those 30 days, you can see that, again, of course, aspirin is going to create bleeding, but actually the placebo then catches up with the aspirin. So then you don't really see that difference in the secondary outcomes, the death, CV death, stent thrombosis anymore, which then really led to that recommendation here, where you can consider the first month or 30 days of aspirin in certain patients. But again, it gets complicated in my eyes. But you can see here the strategies, and let's just focus on some decision making you have to make. For example, high ischemic thrombotic risk. So let's say there is someone who has 3 stents, right? You would basically send them out with triple therapy for a month. And then you would switch to just the antithrombotic therapy, which is P2Y12 inhibitor. Plavix is preferred, ticagrelor as an option, and an oral anticoagulant preferred the NOAC. And then after 12 months, you go back to just the oral anticoagulation. If you have the reverse, if you have ischemic risk that's low, but thrombotic risk, the high bleeding risk, then you can, of course, avoid this 30-day therapy, triple therapy, and even maybe shorten the dual antiplatelet therapy. Now, I really looked hard in that paper. If you have both, high thrombotic risk, high bleeding risk, nobody really has an answer. I think that's, again, completely up to us then to decide. But one little thing that I think is going to throw maybe a wrench in even that recommendation is this study that came out that compared what we use as the Onyx stent one from Medtronic, for example, against a stent that was really superior against a bare metal stent. And if you then compare our Onyx stent against that superior stent, you can see that the Onyx stent for 1 month dual antiplatelet therapy alone in high bleeding risk patients performed similar. So essentially saying, as it said here in the conclusions, that if you really have a high bleeding risk patient, and 50% of these patients had also acute coronary syndromes, you can consider actually dual antiplatelet therapy for only 1 month after PCI. So there's a lot of shifting here in this whole field of post-PCI dual antiplatelet therapy. So that's why I have that last slide here where I think maybe in the high bleeding risk patients, the error might even shift a little higher here. We can consider something after 1 month to go back to oral anticoagulation. Of course, that has to be shown, but I think in certain patients we could consider that. In summary, I think dual versus triple antithrombotic therapy is an individualized decision still. I think we still have to see what everybody in our group, for example, would think. We might come up for you all with one template. Don't use dual antiplatelet therapy for more than 1 month. So really the triple therapy, I think we all don't do that more than 1 month. Prasugrel is really not in favor, but you can consider ticagrelor. And then with this Onyx 1 study, you really have to think maybe 1 month of antiplatelet therapy, dual antiplatelet therapy is actually enough. So I thank you for having me participate, and I think now we're going to be happy to take the questions, and maybe we have JoEllyn actually lead the whole thing.
All right. Well, thank you everyone for joining us. Thank you to Drs. Gössl, Moore, and Skeik for presenting. We really appreciate you sharing your time and expertise. As Dr. Gössl said, at this point, we're going to open it up for Q&A. As a reminder to the attendees, the only way to submit a question or comment is by using the Q&A pod, which is located at the bottom of your screen. Dr. Skeik, if you could start your video and unmute your microphone, we would invite you back at this point.
Yeah, I actually did, but it asks you to start my video. I started, but it says that you need to start that yourself.
All right. Well, I just clicked on it there, so we should be good to go.
Yes. Yeah, there I am.
All right. Well, thanks again for joining us. The first question in the Q&A pod is for Dr. Moore. Dr. Moore, to clarify, in patients with paroxysmal AFib and a CHAD score of 0 out of 1 who receive cardioversion within 48 hours of onset, is there no need for temporary anticoagulation after cardioversion?
So by the guidelines, I would say that if your CHA2DS2-VASc is 0, most of us say that would be okay to do cardioversion without anticoagulation. Although there's certainly evidence that the closer you are to 24 hours with onset of atrial fibrillation, the safer the cardioversion. And I would say if there's a question of someone maybe sneaking up into the higher CHA2DS2-VASc score, if they're pre-diabetic, very close to 65, or have kind of borderline risk factors, I would say we probably, in the electrophysiology section, err on the side of anticoagulation for a month, just because of the likelihood, unless they're a very high bleeding risk patient, the likelihood of bleeding in a month should be quite low for them. And so I said, in general, they don't need to be, but there are certainly caveats there.
Excellent. Thank you very much. The next question is, should all patients on AC or DAPT be on PPI? And I think that's for anyone to answer.
You mean after intervention? Is that what the question is?
So the question is, should all patients on AC or DAPT be on PPI?
Oh, PPI. Well, it depends. I'll take that question. It depends actually on the bleeding risk. So there is more emerging data now for direct oral anticoagulant to use PPIs to reduce risk of bleeding. So I think PPI, as long as there is no contraindication for PPI, which is rarely there is, I would consider that, especially in patients with increased risk of GI bleed. But if I have a patient with kind of concern for GI bleed to start with, my kind of first option would be either apixaban or edoxaban, because both showed really kind of balanced risk versus warfarin, though the other two agents showed more GI bleed. So for antiplatelet therapy also, if the patient is going to go on antiplatelet therapy, if there is no risk, if there is no history of GI issues, not necessarily, but if there is a history of peptic ulcer disease or previous or recent GI bleed, then yes, PPI might be added.
Excellent. Thank you very much for that answer. This question is specifically for Dr. Gössl. And Dr. Gössl, would you suggest that any CAD patient with an indication for OAC should stop all antiplatelets after 1 year following stent placement or any form of ACS?
Yeah, again, I think none of our answers should be any and ever and always. That unfortunately in this whole topic, I personally believe that is not possible. The statement, though, would suggest that after 1 year, yes, you can put the patient back on oral anticoagulation and it should be fine. I think you will have, of course, outliers in one or the other way, but in general, that should be possible. And I think most of us actually do that. Now, you will have a patient who has the third stent in a left main bifurcation. Am I then super comfortable with that? And is there any data on that? I don't know, probably not. But I think the general comment would be yes, and otherwise I would always recommend to send an EPIC inbox or give a quick phone call to the interventionist who actually did the case, so not just the one who was on call, and say, do you remember that case? Can you look into that? What do you think? And I think we will all give you a careful answer on that. And I think Ivan had a question there too, and that just signifies the problem, right? He's asking, what do you think left main, LAD bifurcation disease, history of stent thrombosis? Yeah, that's all part of a conversation to have. If someone had a second stent thrombosis, am I going to be comfortable with any kind of all these recommendations, or would I say, well, maybe he should stay on aspirin longer, or, but I think these are the recommendations or discussions we should have then, antithrombotic versus, triple therapy and the risks. And it has to be an individualized decision between the interventionalist and the referring physician and the patient then too.
I'm just going to add to Dr. Gössl's point here, and I completely agree with you, but I get this question a lot in my clinic. So patients had a history of, need for anticoagulation for DVT, but had history of coronary disease, but now stable is beyond first or 2 years. And there is actually emerging data now to say that if the patient has stable coronary disease, not necessarily patients that have PCI in the past, that should these patients be on antiplatelet therapy in addition to anticoagulant. The data showed actually that there will be increased risk of bleeding without significant risk of without significant reduction of risk of thromboembolic events. So, but again, we need more data for those ACS patients post-intervention beyond the first year.
Excellent. Well, thank you very much for that thorough answer. Looks like we have a couple questions left, and the next of which is open to anyone to answer, but what is your recommendation for the type of anticoagulation for non-valvular AFib in a patient around the age 85 to 90?
So I'm happy to take that one. I would say in patients who are 85 to 90, of course, they're probably the highest risk for stroke just by virtue of their age, and most likely they have other risk factors for stroke as well. I think it's always an individualized decision, as Dr. Skeik and Gössl have said. And I imagine many of the options may be a little bit challenging for patients, but warfarin can be less expensive, but it's considered to be inferior in terms of bleeding events. So I would say I tend toward apixaban in the elderly population. Sometimes its dose is decreased based on their age and potentially their weight and their creatinine clearance. But certainly they're still considered to be very high risk for stroke. And we always talk about fall risk, and maybe their fall risk would outweigh their risk of stroke. But there were some papers early on showing that you have to fall a very large number of times to outweigh the benefit of anticoagulation in these patients. So.
Interesting. Thank you very much. Looks like we have one question left in the Q&A pod, and that is for Dr. Moore. And the question is, prior to the CHADS VASC scoring system being developed, how were patients risk stratified for thrombotic events?
So actually the CHADS-2 VASC score was an extension of, which was published in 2010, was an extension of the CHADS-2 score, which was published by Gage and his colleagues in 2001. And that was really the first standardized approach to risk stratifying patients for atrial fibrillation and who should and should not be on anticoagulation. Of course, warfarin, although it was approved for use in 1954, the studies supporting warfarin for stroke prevention and atrial fibrillation were published in the early 1990s. So I imagine, and actually to get into all the details for what were considered to be higher risk factors then, Dr. Gornick would probably, I know he was involved in some of the early trials with warfarin, but certainly in the 1990s is when people started elucidating what were the risk factors, and it was standardized in 2001.
Just quick comment, for the previous question about the elders, and unfortunately, I see a lot of elders without being on anticoagulation, and I completely agree with you, Dr. Moore, that we kind of missed a lot of elders not on anticoagulation because worry about, bleeding. But as you mentioned, completely, those patients have also high risk of thromboembolic event and bleeding. So I think it's kind of weighing the risk and benefits, and so I just, it's very unfortunate that we see quite often patients really come, with a stroke and they were not on anticoagulation because they were elders. So I think, I completely agree with Dr. Moore.
I also wanted to make a quick comment on the Watchman things that you brought up, JoEllyn. So
yeah.
I think this whole TEE question, for example, I think, and it's great that you guys come up with a guideline, because that question comes up.
We're getting there. I wouldn't say it's necessarily our guideline yet, but yeah, we're evolving for sure.
Yeah. So and I just reviewed something here by someone who had an urgent request for a paper here in the PCI literature. And they were arguing, why are we doing actually TEs at 45 days anyway, right? So basically the whole question is, yes, you see some thrombosis every now and then. Does that actually lead to TIAs? Well, in some, but how do you know it's from? So the whole, I think, field was going to shift at some point there anyway.
Particularly in the COVID era, who needs a TEE? That's
right. And then you might be able to do a cardioversion without. And the other thing is, if anybody has a patient who is not really a good candidate for warfarin after a Watchman, just have that conversation with Riot or myself, because we can certainly use the ASAP2 protocol, which is just dual antiplatelet therapy. And in Europe, that's done all the time already. It's part of the guidelines actually, or CE approved. Let's put it like this. So we can discuss that. It's not that we want to do it all the time, but if someone has a warfarin issue at all, I mean, like heavy bleeder, et cetera, let's have that discussion just one-to-one, and it's not just a no from the get-go.
That's wonderful. Thank you for sharing that, Mario.
All right. Well, thank you, everyone. Thank you for your questions. Thank you for joining us today, and especially thank you for our presenters. And to our presenters, is there any final words that you would like to say before I sign us off here?
No, thanks to my colleagues. It was a great group.
Great collaboration. Thank you.
Yeah.
All right. Well, thank you to everyone, and thank you for joining us today. This was the final grand rounds for the spring season. Please take a few minutes to fill out the series evaluation that was emailed to you, as your feedback helps us plan and improve. Keep an eye out on the grand rounds website, where we will post all the fall sessions as they are planned. And on behalf of the Minneapolis Heart Institute Foundation and the education team, have a great summer, and we look forward to starting back up in September. So thank you, and have a great day.
Thanks, everybody.
Bye.
Bye-bye.
Thank you.